So we have a full day. We're gonna be very informal, and please ask questions as we go. I'm gonna do an overview, and then Paul's gonna carry the load for the rest of the day. But we are very informal and want this to be very interactive and dynamic, so please, as we go, if you have questions, don't hesitate to stop us. Just a few slides about WEO. For those of you who are new users of WEO or new to the WEO organization, what is WEO? We are an all-payer claims database. We are a voluntary public-private initiative. It's a partnership that brings together stakeholders in Wisconsin to develop this statewide data mart that has information that spans providers and systems. As I said, we're a voluntary public-private 501c3 corp. We are not legislatively mandated or government controlled, which is somewhat unique among all payer claims databases or APCDs across the country. There are a number of them nationwide, but we do not restrict access to the data. All of our member organizations and users have equal access to the information. We, or I should say Optum, our technology vendor, aggregates claims data from 16 participating organizations. Some of you are representing the payer organizations that contribute their data that make up our data mart, as well as the state of Wisconsin Medicaid claims. We have data on almost 2/3 of the population in the state, so we have an unprecedented volume of data that's accessible to as many users as we do. The member organizations you see here on the left are our founding members. WEO was founded around 2004, 2005. The asterisks indicate these are payers who are contributing their data. And the plans on the right are additional data contributors that have joined WEO since 2005. Why did WEO get going in the first place? Well, the founding leaders recognized that there was the collaborative at the time who was collecting clinical information, but there was really no equivalent organization collecting financial data, that which you could use to measure resource use and process measures. So the goals really was to aggregate healthcare data from a variety of sources to create a single, reliable data source on which to measure efficiency, quality, safety, and cost. And with the ultimate goal to improve healthcare delivery in the state of Wisconsin. We support provider quality improvement initiatives and ultimately to encourage value-based healthcare choices by consumers. A little bit about the data mart. Some of you have been using it for a while, some of you are brand new. We produce data marts twice per year, and they consist of a rolling 27 months of claims and eligibility information, both medical and pharmacy data. They are published in October and in April. We missed the April deliverable this year because of some data quality issues and timing of the availability of data. So for the first time in 5 years, we did not publish an April data mart, but we expect the fall data mart to be available around end of November or December 1st. We're a little bit delayed because of a few issues. Software migration to a new version. We had some delays in data submissions and some enhancements that were being incorporated. So we're a little bit delayed, but we do expect data mart version 10 to be published around the 1st of December. Data quality, usability, actionability, those are the key drivers for WEO. We are an organization that our only asset is our data mart. So we need to make sure that that data is useful and timely and accessible to all of you. WEO and Optum Insight works closely, and we also have a data mart quality and value work group that I chair that is continually looking to improve and enhance the data mart and its quality. Next. This is a chronology of the data marts going back to data mart version 2. The first, which was really sort of the first steady state, data mart version 0, which was sort of a beta test, and data mart version 1 were Optum and WEO working to solidify and stabilize the data. So Data Mart version 2, published in October of 2009. You can see each subsequent Data Mart every 6 months has grown. Up until Data Mart version 8, we didn't add any new data contributors in Data Mart version 8. But you can see we have close to 4 million members, 250 almost million claim lines, about 2/3 of the state of the population. 40% of the claims are commercial. 46% are Medicaid, split between fee-for-service and HMO. And we have 14% of the claims being Medicare Advantage. Now, Medicare fee-for-service data are not incorporated yet, but we, in July of this year, became a qualified entity in the eyes of CMS, which means that in 2014, we'll be able to bring in the claims and eligibility information for almost another million members, those that are insured by Medicare fee-for-service. Next, Paul. I'm going to walk through a little bit of the details about how the data are acquired. We have, for initial submission, we work with data contributors to produce what we call a full and conforming data extract according to the WIO and Impact Intelligence data specifications. All of the medical and pharmacy claims, eligibility, demographic and provider data are integrated, matched across data contributors, and monitored for completeness and quality. WIO and Optum reviews data quality for each data mart. There are rigorous QA processes, data intake processes, and checks along the way to ensure that all the data that make it into the data mart are accurate. There are a number of data transformations that are somewhat unique. Impact Intelligence is a product that is used widely among both payer and provider organizations, but they're generally not integrating data across 16 different sources. So there are some data transformations that are unique to WIO that I want to just touch on, and we'll touch on them throughout the day. The first being member matching and de-identification. So members are matched both within and across health plans. What that means is, as a member, as a healthcare consumer, I might change jobs and have health insurance across different plans. The intent of WIO is to represent a person once and only once across plans for the sake of episode grouping and longitudinal analysis. The member PHI is de-identified, so you won't find a name or an address or a date of birth anywhere in WIO. But you do have a unique member ID, which is persistent across data marts. You have the patient's age in years, and you have their gender. Provider matching is another critical component of the data intake process. Again, both within and across health plans, provider identities are merged, and with the intent, again, of representing a provider once and only once for the purposes of doing performance measurement. We apply a standard pricing methodology, which essentially levels the playing field, if you will, as far as unit price of services goes. And what you end up with then is the ability to do resource use analysis rather than analysis of geographic differences in costs of services. And we'll talk more about standard pricing in a little bit. Peer groups. This is another critical component in provider measurement. It establishes homogeneous peer groups with which to evaluate individual providers and groups of providers to a meaningful peer group. And lastly, we apply provider affiliation information that allows you to roll up physicians and clinics to the overall health system in which that they are employed. A little bit more detail about member de-identification. These are the de-identified data elements. Like I said, you won't see name, address, social security number, date of birth, etc. All of these data elements are used to do member matching across data sources, but the data that are available at a member level are gender, year of birth, a persistent ID, a member zip code. A little bit about that. Because of HIPAA privacy guidelines, the zip code information, the true zip code of the patient is rolled up to a county level, and it's based on 3-digit zip code. And finally, dates of service, diagnostic and drug codes, all of the patient claim line level detail is fully available in the data mart. Again, a little bit more about member geography de-identification. 20,000 people in a county, or I should say in a 3-digit zip code, is the guideline that's applied. If you flip to the next slide, Paul. This will give you an example for what I mean by de-identification. So Bayfield County is a good example of a county where in the 3-digit zip code, there is not 20,000 people in the population. So they have been reassigned to Ashland County. There are some counties like Adams where there is, at a 3-digit zip code level, there is sufficient population. In 539, those patients will look like they reside in Adams County. But if your zip code begins with 546, those patients have been reassigned to La Crosse County. Next. So this is a Data Mart version 8 member count by county. The counties that are white are all of the ones that are de-identified. Next. Provider matching and standardization. So one of the features of Impact Intelligence allows you to measure the efficiency and the quality of individual or groups of providers. In order to do that, our intent is to represent a provider only once, and using these attributes and demographics of physicians in the pre-processing steps of Impact Intelligence, those provider records from all 16 organizations are merged and matched in order to get down to a unique occurrence of a physician. Next. Standard pricing, a little bit more detail about that. It's really the process of creating a uniform and consistent approach to classifying medical services and pharmacy services. It removes variation that exists because of geography, because of different charge structures, time frames, and it really results then in a measure of resource use rather than cost. And that's an important thing to remember as we're going through the training today. When we're looking at standardized cost, it's really a measure of resource use and not what a health plan or a member might have paid out of pocket for a healthcare service. The methodology does vary across types of services. We have a slide deck that we can get into some more detail later today about how the methodology differs by type of service. Essentially, on the inpatient side, the standardized cost is driven by length of stay and a per diem. On the outpatient facility side, because of the way outpatient facility services are billed today, the methodology essentially applies a percentage off of billed charges as the standardized price. But for the other types of service, professional, ancillary, and pharmacy, it's really a unit-based standardized price that's applied. I will mention with outpatient facility services, there's been some enhancements made to the algorithm, and I think it's 2.1. So in the spring deliverable of next year, the outpatient facility standardized price will be enhanced to take advantage of a relative value-based pricing, and it will look at the service code if there's one on the claim line. WIO has a few custom fields that have been added that are available for reporting. I wanted just to highlight the cost fields. What WIO has in the data mart is the billed amount, that which was put on the claim, and the standardized cost, which I just described, and for Medicaid patients only, the actual allowed amount by Medicaid. I want to underscore Medicaid only because if you are using the allowed amount as a cost field in your analysis, and you have both commercial and Medicaid and Medicare patients in your selection, you have to be aware that the allowed amount is only valued for those Medicaid patients. We have geography based on 3-digit zip, so we have a region definition that we can look at once we get into the, we won't be able to look at WIO? You can look at WIO. So we'll show you what those regions are and how they're defined. We have what's called a member exclude field, and this is important, especially if you're looking at episode-based measures, financial measures. The exclude field is valued to specifically enable you to pull out patients who don't have what we consider complete claims in the data. So patients who might live out of state all year or maybe part of the year. Medicare fee-for-service claims certainly won't be complete. And then also there is an attribute that allows you to see whether a patient has a pharmacy benefit. And Paul will get into the importance of that as we're going through episode conversation. We have the tax ID or provider TIN. We have an attribute for whether a member is in a fully insured or an ASO plan. And then there's a product hierarchy that delineates commercial from Medicaid and Medicare. About our resources, there are WIO staff. We have 80% of WIO here in the room today. Duke, Jimena, Andrea, and myself. And we are accessible by email and by phone certainly at any time. The Optum Help Desk and Client Support is the primary resource for technical questions or methodology questions that I can't answer. And there's self-study modules, Optum account management staff and subject matter experts. Paul is one of the subject matter experts that I draw upon when there's questions that I can't answer. And there's really a plethora of subject matter experts and resources available to WIO should we need to draw upon them. There are computer, internet-based self-study modules. Anyone who is new to impact intelligence, you are welcome to take advantage of those. If you need more information, you can email me and I can send those to you. Basecamp, also known as the Hub, is a terrific resource where we put all of the reference materials for the product, past training materials, past presentations, white papers, a whole host of information that you can draw upon. And if you're not set up to access the Hub, please email me and we'll make sure that you get that set up. Any questions on all that WIO stuff that I just went through before we get back to regular scheduled programming? A zip code mapping?
Yeah, because it has just 3 digits, and when you click on the 3 digits, you really don't know what's the
From a member perspective, the true zip code past the first 3 digits is not available. If you're looking at provider zip codes, there is a provider zip code field that you can use separately from that 3-digit zip code. So always remember that true zip code from the patient is not available. But the zip code of the provider is. Good question. Any other questions about WIO? Yes, Bruce.
Provider affiliation, is there a crosswalk available for that affiliation?
The provider affiliations, we are provided by the Wisconsin Medical Society. They have a continual ongoing process by which they're collecting physician demographics information and managing specialties, affiliations, locations, clinic, and while there's, as far as a crosswalk goes, there's nothing that I can, send you in a spreadsheet. But that information, once you get into the reporting system, there's certainly places where you can go to see down to the physician level who's involved, who's assigned in which location and in which specialty. Raj.
Sorry, if I remember correctly, in our previous conversations, you had mentioned that although we have about 65% of the state population, the calculations in some component of WIO use a much smaller segment of people. If I remember correctly, it was 20% or 15%, something like that. Could you throw some light on that? I remember a conversation a few months ago.
Okay. Pardon?
That's probably the episodes triggered.
Are you talking about the episodes that are incorporated into provider network assessment? Yes, it's sounding like, that sounds like the track that you're going down.
I don't want to jump the gun.
Yep, and we will be definitely talking about that. As far as the percentage of the population, if you're talking about people, and that about 2/3 of the population. The biggest gap that we have there, obviously, is the Medicare fee-for-service lives. And once we incorporate that 900,000 to 1 million or so Medicare lives from Wisconsin, our biggest gaps then are the uninsured, some self-funded employers where we don't get those claims, and any sort of out-of-state payers that might have lives here that they insure in Wisconsin. So those payers that you saw on that slide where we have of all of our members, those are the 16 data sources. And so Cigna or Aetna, any national carriers that might have a small presence here are not in our mix, as well as any border health plans like Health Partners or Medical Associates. So other than that, we think we have a pretty good representation of the commercial population. But I think, Raj, the thing that you're sort of honing in on is really more about episode capture and the episodes that are included in the provider measurement. And we're going to talk a lot about that today.
I just wanted to understand how we're working with the full data set when we do some analysis and a subset.
Yep, and Paul's got great slides that show you in some places you are looking at the whole 250 million claims, and in other places you're dealing with a subset of the whole. Any other questions? All right, I'm going to hand it over to Paul. Not touch any buttons.
Right. Not touch any buttons. Okay, so what we're going to be doing today is we're going to be doing an overview, or basically what's called an end-user training of impact intelligence. There is one minor difference in the training we're doing today versus what you're seeing in your application when you go to your home site. You're going to be using Impact Intelligence 1.3. That's the current version that you have sitting out there. The slides and all the material we're going to do today is 2.0. There are very minor differences between the two. The biggest difference you'll see is in 2.0, you're going to get a new quick list, which is called confinements. That's the biggest change that you're going to see between the slides and what you're going to see. And then when the new version becomes available, I think it's December 15th, thereabouts? Early December. Then these slides will be 100% applicable to that particular one. Yep, thanks. So what we're going to be going through here, first of all, is where you can get information. Now, the hub, which Sarah has mentioned already, is probably the best place for you guys to get your information. WEO's done a great job of grabbing everything from this, which is our client portal at Optum, and sticking it out there. Some of the things you might need are concepts guides, methodologies guides. You might want to look and identify things like what is an ERG, what's an ETG, how do they work. That's all on our site, but it's also sitting out there on the hub. So I'd go to the hub first, and if you can't find it on the hub, you're certainly welcome to go into here as a client. In this case here, let's see, I got to get on this side, I'm sorry. What is impact intelligence? So impact intelligence essentially is going to take all of the raw claims, all of the information from all of these payers, and it's going to combine that with the member enrollment. You guys don't do lab results. If you did, they would be included in the system. You're going to look at some provider information, and then what we do is we standardize that data. So, for example, things like place of service. Well, we use the CMS places of service. So if there's any stuff coming in from any of your payers that isn't standard to place of service, we're going to standardize that for you. Types of service get standardized. CPT codes, revenue codes, etc. Now, as everybody knows, these days, almost everything is standard. So stuff coming in from the payers is very, very consistent. And then what we do is we run them through a set of groupers. And these groupers are the symmetry groupers. They're ETGs, episode treatment groups, ERGs, episode resource groups, and EBM measures, or evidence-based measures. And you'll hear me use those acronyms quite frequently. Then what we do is we give you the ability to customize your queries and reports. So within the front end of the application, which you'll see in a few minutes, it has the ability to create any report you want. Now, it doesn't come with a whole lot of reports. It only comes with 2 reports out of the box. But it gives you the ability to create a report and save a report. So if you think about this almost like a blank Excel spreadsheet when you get it, Excel gives you the tools, it gives you the methodologies, it knows how to add and subtract in the background. This is pretty much the same thing. Basically, we have all the data sitting there, and all you guys have to do is figure out, what do I want to look at? Do I want to look at inpatient admits? Do I want to look at outpatient stays? Do I want to look at radiology? And how do I want to look at it? Do I want to look at it from a provider perspective? Do I want to look at it from a plan perspective? Do I want to look at it from an overall disease management perspective? So you decide that, and then you put your queries together based on that. It comes in 3 different pieces. We have the processing engine, which Optum is taking care of. We grab all your data and bring it in. You'll see this on the next slide. We have a data mart, which can be distributed to your organizations, and Sarah does get the data mart, as does a few of the other locations here. And we have the front-end reporting system. So Sarah, if you go to the next one. And this is going to kind of give you a really smushed down version of how easy it really is. And it's not this easy. But anyway, we get all the commercial data, we get the Medicaid data coming in, we collect the data. As Sarah said, we do member matching on it. So you have a single member, hopefully, across the entire data set. Now, the reason I say hopefully for both member and provider matching is 100% accuracy on either of those is nearly impossible. So we get in the high 90s, and that's pretty darn good. And for analysis purposes, that's more than enough. And then what we do is we apply standard pricing, which Sarah has talked about. Then we do the member de-identification, so nobody can figure out who the members are. We put it through the processing engine. We have a data mart that comes out, and then you guys, the WEO users, access that data mart via the web browser. You can also access the data mart directly if you have that data mart in-house. So what are we going to do? We're going to look at things like comparing services across. So one of the things you can think about is if you want to see how often MRIs are used by all your zip codes, you can go into the system, you can create a report that says what's the rate per thousand for MRI utilization in every zip code. You can collapse those zip codes to counties and you say what's the rate per thousand in Milwaukee versus Madison. So that's just one of the things you can do. That's basically service comparisons. So any kind of service that you want to investigate and see if there's a difference between communities, if there's a difference between northern and southern Wisconsin, if there's a difference between commercial, Medicaid, you can actually make those comparisons in the tool itself. The second thing is provider performance. Provider performance is one of the premier reasons users use Impact Intelligence. We can tell you, based on all the data in the system, how good a doctor is compared to his peers or her peers. So let's say you have a group of cardiologists and you want to find the best cardiologist, both quality as well as efficiency. This tool can tell you that. And what we do is, I guess this gets to the subset, Raj, that we were talking about earlier. When we take all this data in, we've got millions of claims. Those millions of claims then come back and form what we call episodes of care. Well, not every episode of care actually gets used in provider performance measurement. We need to call out those episodes that are complete episodes of care that are not outliers. And we'll talk about both of those terms as we go along. But what we're trying to do is we're trying to get to a set of episodes that a specific physician's responsible for that are comparable from physician A to physician B to physician C, and then say, how does physician A treat those episodes as compared to everybody else? So what we're looking to do is we're looking to say, if you've got a cardiology episode, which cardiologist uses the least resources and has the best outcomes? And that's exactly what the tool is designed to do. Next, it's good at population-based analytics, disease categories. So if you want to find out which disease is costing you the most money in all of Wisconsin, you can go in there and there's a disease management section of this, and you can actually work your way down to find out, oh, it's asthma, or oh, it's mental health. And we'll see that as we get into the application today. And then, of course, we talked a little bit about geographic restrictions. You can actually look at things from a geography perspective. You have rural, you have urban. You may want to compare the two or contrast the two. So what are the product components within it? First of all, we've got a way to look at physicians differently. So we look at specialty physicians differently than we look at PCPs, differently than we look at facilities. If we're looking at primary care, for example, we can measure primary care doctors in a number of different ways. Episode measurement on a primary care doctor or population measurement on the primary care doctor. If you're looking at specialty, it's just episodes. If you're looking at facilities, typically we use DRGs. And for WEO, we standardize all of those DRGs. So no matter where the DRG comes from, no matter which hospital submits that particular claim, the DRG is going to be the same. Do folks know the difference in what I'm talking about in terms of DRG standardization? Do folks understand that some health plans can have a contract that has a CMS version of the DRGs out there? Another health plan can have a contract with the same hospital that may use APR DRGs. Well, if I take DRG number 429 from this set and DRG 429 from this set, there's no match here. It's a mismatch, right? So what we do is we take all the claims in and we set it to a standard DRG. So when you're comparing hospitals, you're comparing apples to apples. We look at cost of care in terms of episodes, in terms of population, and in terms of inpatients. Quality of care is compliance with evidence-based medicine. Those are the EBM measures I talked about earlier. Those are about 580 quality measures built right into the tool. When you look at those quality measures, they can be grouped into categories. One category might be HEDIS. We do have all the HEDIS measures built into the tool. We're not HEDIS certified, but the measures are almost identical, if not totally identical to HEDIS. Now, this is an area that a lot of folks take a look at and say, well, how do I know what that particular quality measure means? Once again, the hub has documentation on every single quality measure. You can go there and download a PDF file that has everything about that specific measure. The codes required to be compliant with that measure. The codes required to actually make that measure. So for example, if you're talking mammography, how do you know who qualifies for mammography? Well, there's a document out there that tells you who qualifies for it. How do you know who gets kicked out of that particular category? Well, the document tells you who is kicked out of that category. So you can actually identify exactly what those measures are by going in there. And what a lot of plans will do is they will take these quality of care measures and select 10, 15, 20 of them that they really want to work on, look at them, and use the tool to just look at those particular measures. That's not to say you can't look at all 584. You certainly can do that as well. We have the ability to create a definition of performance. What is performance? What's performance for a PCP? What's performance for a specialist? And at the group level. As Sarah mentioned, the groups are all combined by Wisconsin Medical Society. So there's a standard set out there. And somebody asked, can I get the affiliation table? One of the things with the affiliation table is it sits behind the tool, guaranteed. So sure, you can go in there and you can roll it all out. One of the problems with distribution of something that large is it typically doesn't fit on an Excel spreadsheet unless you're in the most recent version. I think it's 2010, because you have how many doctors, Sarah? A lot. A lot. So it exceeds the spreadsheet. But you can still get the other affiliations. And if you look in the tool, or you happen to get the data mart, you have that table right there. And then we also look at facilities. Go ahead. Okay, so you guys don't have the employer piece of this, but we can actually compare across Wisconsin by product and by geography. And quality measures are looked at for not just quality, but we look at them for unnecessary services. So for example, if every time a patient comes to your office and you're an ENT doc, do you do a radiology exam? Maybe it's not warranted. So we look at it there. And we also look at it for patient safety. So there are rules around each one of those. We're going to analyze diseases by prevalence, by cost, by utilization, and by health risk. Does everybody understand what health risk is? And does everybody understand the difference between episodic risk and overall risk? Yes? Okay. We're going to dive a little deeper into that as we go along. We're going to look at separate diagnostic management and treatment service categories for looking at cost and use. Now remember Sarah said that in some cases we use all of the data, and in other cases we use just a subset of the data. I've already talked a little bit about using episodes, which is just a subset of the data to compare physicians. But when we start looking at the cost and use sections of the tool, we're using all of the data. Now, that's not to say within the tool you can't filter out some of that. So if you wanted to see only the Milwaukee data for cost and use, you could filter it by that. If you wanted to see only the data that applied to diabetics, you could filter everything out for that. So the tool is flexible enough to allow you to filter and separate so you can see specific cost and use for specific items, whether it's a disease category, whether it's a geographic category, whether it's a provider measurement, a facility measurement, etc. You can actually cut it down. We look at it by health risk, by the overall patient, and then we can also look at it by product, by employer group, by geography, and pretty much any other slant you want. So if you wanted to compare the health risk in Wisconsin by northern, southern, eastern, western, you could actually find out what the health risk is in each one of those. If you want to further define that and say, let's exclude the Medicaid population. You could do that as well. So pretty much anything you can think of, the tool can actually do in either the quick lists, which we're going to see in a second or two, as well as the online cubes. And the online cubes are essentially what I consider a huge pivot table. You can put anything down one dimension, anything across the rows, and then you can put any set of data you want in the center of it. So pretty flexible. Go ahead, Sarah. You guys don't have this particular one for that, so we're going to move right through it. This is kind of the way it works. Lab results are crossed off because you guys aren't supplying those. One thing to note about lab results, though, is when you're looking at your quality measures, some quality measures require lab results. I'll give you an example. We have diabetic measures in there, and one of the diabetic measures is, did you get your A1C done this year? That doesn't require a lab result. That just requires a claim. Yep, you got it done, right? But then we have 3 other measures in there that say, was that result less than 7? Was it between 7 and 9? Or was it above 9? And that's kind of like stratifying your population now, right? Those 3 won't kick in the application. Why? Because you don't have lab results. Not going to happen. So you got to pay attention a little bit when you're looking at quality measures. Do you require lab results? The second piece of this is, even though you are getting in RX claims here, there may be members in this population that don't have coverage for RX. What does that mean? That means that if you select one of the quality measures that requires an RX to actually make it compliant, and you don't filter out the members that don't have RX, you're going to get a whole lot of members that are, quote, non-compliant in there, but they don't have RX. Now, another unique thing and it's across the country, it's not just Wisconsin, even though the member has RX coverage, right? They may go to CVS or Walmart or Walgreens and do what? For $4 get their generic, and nobody knows the better of it, right? Why would they pay $25 copay when they can get a $4 generic? So you have to be aware of that when you're starting to look at your numbers. And in some areas of the state, that may be more prevalent than other areas of the state. So when you're looking at your numbers and when you're looking at your results, keep in mind you need to know the population that you're dealing with. So we take all this information in, we run it through the processing engine, and I've already said it includes ETGs, ERGs, and EBMs, and then we throw it into a data mart, and that data mart gets looked at through the reporting system or the website. And on that particular reporting system, we have 4 different areas. We have management reports. And this is one of the areas where we give you a predetermined, here it is template, go ahead and print it. Have you guys heard of the Bucky Badger report? Yep, that's one of those predetermined reports. We have quick lists, which allow you to actually go out and provide a table for yourself based on a set of filters, and we'll see that in a second. We have cubes, and that's what I call my ad hoc or my online analysis or my pivot tables, where you can do pretty much anything with the data in that area. Okay, Sarah? Sorry to keep bugging you over there, but it's hard to go back and forth. This just gives you pretty much a quick layout of what's going on, and these are the standardizations that we take into account. So we'll come in there for the analytic categories. We've talked about type of service. We've talked about place of service. Specialty is another important one. The Wisconsin Medical Society, again, I believe, tells us what the specialty of the particular provider is. That specialty allows us to put the provider in the right peer group. So if we are told that the specialty is cardiology, they can get put in the cardiology peer group. If we're told it's chiropractics, they can put in a chiropractic peer group. So if the physicians have any issues with where they are, they should go back and say, okay, we need to change that specialty because that's not what we really do. We don't practice like that. The other categories that we do, product, line of business, account, group, practice, all of these are standardized so that when it comes out at the end of the tool, you don't have a trillion categories of anything, right? You've got a standard set of categories. Like place of service, there's probably about 30 places of service that are in the tool. So you don't have 50 or 60 or 100, and you don't have one for each plan. You've got a standard set. Next, Sarah. So we're not going to log into this particular one right here. What we are going to log into is we're going to log into the demo system. One of the, I guess, good parts about Impact Intelligence is that it's highly secure. And be that as it may, what it does is it actually looks at IP addresses coming in, and it says, are you allowed to come in based on your IP address? Well, we did try to get this place set up that way yesterday. We thought it was all set. We tried it this morning. We're not getting in. So what we're going to do is use what we call a demo site. The demo site works and looks just like the WEO site, except it doesn't have your data in it. And we'll actually use that for some stuff. So what we're going to log into, and I guess I'll write it down up here. forward slash? Wait a minute, I got set
Yeah.
myself. Yeah, forward slash. And actually, you can oh, they can't see that. That's interesting. Okay.
It's way up there.
It's way up at the top. It's hard to see though.
I can read it to you.
Oh, okay, good.
Demo
Demo.
to optiminsight.com/demo capital II.
Yep. That's all even. The rest of that's just trivia. And that's what you should come up with. So everybody, if you want to give that a shot, throw that in there, hit it, and you should come up with a little pop-up that essentially asks you for your ID and password, right? So you're going to go in as me, because this is a demo system, and it is, for the first one, it's going to be small p, small l, A, G, A, S, S, E.
That's lowercase I.
Oh yeah, I'm sorry, I. And then for the next piece of this, it's going to be, again, a small p, a small l, and then a capital I, H, I, C, C, I, H, C, I, S. I'm sorry. C, I, S, 950. Can't even remember my own website.
Easier to type.
Oh, it is easier to type, far easier to type. Okay, have people been able to get in so far?
It's not 950, I think it's.
No, that's mine. IHCI.
I got
You got in? Yeah, that's what it is. Garen, 950. Really? Do you want Google to save your name? Try that again. Now get rid of the pages. Boom. There it is. You're in. Yep, everybody's in. Okay, everybody in? Not yet? Okay, so we got a couple folks that aren't in.
What are we looking at here?
2.0, 2.1, excuse me, 2.1. So it's not the one that you're using.
Because it looks different than that too.
Absolutely it does, because what you're going to see in yours, right here, confinements is the key that tells you that you're in a new version. You don't have this at all. Confinements is
Okay.
missing.
I wasn't sure if it was just the slides or this too. Okay.
Yep. Okay, so who isn't in, so I can help you out?
Some people might need to actually click on that compatibility mode.
Ah, that's a good point. The compatibility mode. Although nobody else has had to do that, right?
He doesn't have this, like, that
Okay, so who's not in? I'll just walk around and help you. Here we go. Okay, so it's P-L-A-G-A.
Oh, okay.
It's not. It's small. And it's P-L-I-H-C-I-S. 0. Boom. Yep. Bingo. You're in. Okay. Okay. Anybody else? No. Whoops. Oops. Sorry. Sneak my way by. Okay. Everybody here is okay? Okay. We'll give Sarah a couple minutes back there, and then we'll get going.
Do we have to do anything with compatibility, or just if we couldn't get to it?
If you can't get to it, do something with it. Now, the only thing that you may see, and I'll show you this right now, and you can identify if you need to do compatibility mode. If you come down and you roll your way over some of these, you should see a drop box pull off to the right. If you do not see a drop box pull off to the right, go to compatibility mode.
Thank you.
Okay. Okay, so now what are we going to do from here? What we're going to really do at this point is we're going to walk our way through each of these sections here. And in this particular demo version, the top section is identical to what you have in WIO in 1.3 now. This section is identical to 1.3. Yes,
I
sir?
don't remember seeing the sensitive data report.
That may or may not be there if you have permission to see that. You also don't have permission, and we'll see it down below, there's another administrative module which you may not have permission to see. This shows you absolutely everything because I'm in there as an administrator. So there are certain things you may or may not be able to see based on your rights into the system. Yes, sir?
Now, you were saying that the version is going to change.
Yep.
Will that be transparent to the user, like all of a sudden it'll be a different version?
Yep.
So they don't have to do anything?
They don't have to do anything but log in, and
All of a sudden there's a difference.
Yeah, the biggest difference most folks see as users is the confinements will show up.
Okay.
The other thing, if you're looking to see which version you're on or what the data set is, one of the things you can do is you can go down to the bottom of the application, and right down in this area here underneath the Optum, it will actually tell you down in there what the published date is, what the product version is, etc. So you'll be able to see what you're looking at right away.
Thank you.
Okay, so in this case here, up at the top, you see that we have something called My Reports. We've got public reports and group reports. You all may not have all of those on yours in 1.3, but they are all available to you. My Reports refers to reports you created under your ID. So if you guys were to go in there and you were to hover over My Reports right now, you're going to see all the reports I created out there. So it's going to be My Reports because you're all logged in as me at this point. If you go to Public Reports, you're going to see any report anybody's created. So there could be thousands of reports out there. And we encourage our clients not to let anybody throw stuff out there. But and some clients have hundreds and thousands of reports out there, and it's really hard to manage. If you're in group reports, and if you go down and you hover on the group reports thing, you're going to see I'm a member of two groups, the admin group, and I think it's the BSG group. And Sarah, if you want to just hover over that, you can do that. Group reports. Yeah, Administrator and Impact Demo, that's me. Under each one of those, I have different reports. So how is that used? That's used, say for example, you have a economics area within your company. You have a case management area in your company, a disease management area in your company. You can actually have WEO set up roles for you, and those roles can be different. And then you can save reports that everybody in that little role can actually share. So everybody in Impact Demo here can share this, but not everybody's a member of Impact Demo.
I've
So-
set up many organizations with a group reports folder, I call them folders.
Yep.
For your specific use within your organization.
Mm-hmm. Let's see. Okay, so that's group reports. We have a manage reports section that you may or may not see based on, or you will see it for your own reports, but you may or may not see all the reports because you're not an administrator. A download reports section, which we'll see why that's there in a few minutes. Profile options section, and a sensitive reports section, which you probably won't see because it's only administrative rights. Down here under management reports, we have two types. We have the physician network assessment reports. These are the reports where you compare Dr. A against Dr. B against Dr. C, or Group A against Group B against Group C. So within provider network assessment, you can look at it from an episode perspective, where you can look at it from quality or population. You can look at it from a physician population perspective and how the quality is doing. Or you can actually create a profile, specialty physician profiles, group affiliations, PCP profiles, or PCP affiliations. And we're going to actually go in there and create one of those in a little bit. You guys don't have access to the employer piece of it because you guys don't have that piece of functionality. But you can see that one of the things here is that provider network assessment appears 3 times. It appears here, it appears here, and it appears here. Little different slant on each area. If it's up here, this is what we call our pre-canned report. So you're going to get a templated report out that you can modify to some extent, but not a large extent. If you're under quick lists, what you're going to be able to do is you're going to be able to filter for specific characteristics of physicians. Very easy to do, and you can do it at the, as Sarah has pointed out, the list individual physician level or a summarized level, and summarized by the affiliation. Maybe you want to summarize it by something different, but we'll see what that is in a minute. And down here under online analysis, you again have it by episode, by population, and by admission. So admission obviously is facilities. So you can look at it in 3 different ways. If you're a real geek like I am, right? I head right down to here to online analysis because that's what I can do the most of, right? But if you just want to get a quick and dirty report, Quick List is the right way to go because you apply a few filters and off you go. Now, as we work our way down here, on Quick Lists, these Quick Lists work exactly the same way. So no matter which one of these I click on, the first screen that's going to pop up for me is a filtering list. But that filtering list is based on which Quick List you pick. So for example, if I were to pick Provider Network Assessment, and go ahead, Sarah, pick Provider Network Assessment Physician List, the first thing that's going to pop up, and you guys can follow right along on this if you want. is a set of filters. Right across the top here are all the filters that are applicable. Now, take a look at those filters and kind of have in your head that this is a physician filter. Because if we go to any one of these others, the same filters don't necessarily apply. So for example, if I were to look at members or episodes or claims or confinements or quality or cost and use, peer definition really doesn't come into the picture. So that won't show up. So only the things that are pertinent to a specific quick list show up on the filter conditions. So in this case here, in the general tab, you can actually find a specific provider by throwing the provider's ID in. Most folks don't use that because they don't know who the provider is in the first place, right? But you can say, okay, I have to have a minimum number of people in my population. I have to have a minimum number of episodes. I have to have a case mix of over X. So any of these allow you to actually filter the list down to something smaller. If I go to peer definition, and you guys can go over there, what you're going to see is those categories that we talked about before, primary, medical, et cetera. And if you open those up, underneath that, typically you have internal med, family, pediatrics. And if you work your way down to medical specialty, you're going to get all the specialties. So if you only wanted to look at cardiology, you'd only check off cardiology there. And that's all that would show up on the list. So these are filters as you go along. And whatever you put in each one of these filters essentially is an and clause. So what you're saying is, I want something in the general and this peer configuration and the affiliation and the geography and the specialty, etc. Now again, if you're a real geek and you love SQL, oh, I'm sorry, go ahead.
I was just going to ask, so if you wanted to understand what the 3-year provider level was versus the 3-year group level, if you wanted to understand those types of things, do you go to the hub to get those?
Yeah, well, you don't have the 3-year stuff. You have a whole bunch of other stuff. And what we can do, Sarah, if you want to flip over to yours, I think I have, I'm not sure if I called it up or not. Is there another Explorer session open up at the top? I can't see the top. No. Okay. Yeah, why don't you, just pop it in. We'll show you what WEOs looks like. Because WEOs is every client picks a different set of peer definitions. And when you pick that different set of peer definitions, you're actually fine-tuning the application towards your area. This was a demo system, so that's what we picked. But to directly answer your question, how do you know what it means? The Hub is a great resource, or anybody who works for WEO is a great resource because they set that up. Or myself, or Tom Knabel, or some of the Optum folks. So yeah, here Sarah's going to call it up, and this is what the WEO one looks like. And open that up. Now Sarah just hit a button there. I don't know if many of you realize that, but that little button up there, the collapse and expand button, allows you to see a lot more of what's going on. And that's kind of a handy little button to hit. So Sarah, if you wanted to talk a little bit about the
Sure.
peer groups.
Sure. So we have some 40 or more flavors, if you will, of peer definitions. So under primary care, that has the most different options available to you. The first 3 in the list are statewide, sort of canned out of the box, the default definitions that come with the product.
Yep.
So it's, in the case of WEO PCP internal medicine, that's any internal medicine physician that is eligible for that peer group statewide. There are other subcategories that you see, a group that excludes Medicaid. So what that will give you is commercial and what little Medicare Advantage is in the system. Medicaid only will exclude commercial and Medicare Advantage. And then you see 3 that are population-based, and Paul will tell you a little bit more about those population-based peer definitions that are different from episode-based, which is essentially everything else. And then you have 5 regional sets of primary care peer definitions. And the regions are county-based and based on the Dartmouth Atlas. So the primary care folder of peer definitions is certainly has the most options to choose from. There is a configuration workbook that we haven't mentioned yet, but that's on the Hub, and that does describe all of the peer groups, all of the ETGs, all of the quality measures that are included in that configuration. And those are posted on the Hub with each data mart. Does that get you what you need?
Sarah, last week when I was trying to do some analysis of Medicaid performance on asthma versus on the commercial side, I couldn't find anything for Medicaid asthma.
I could find the PCPs, but I don't know if that's about how we are sending you the data, or why are we able to see those specialties for Medicaid?
So asthma is a condition, and it's a kind of an ETG. So what you are dealing with here is the actual physician specialty, and that's how the physicians are grouped into peer groups. If you wanted to zero in on asthma, the condition, there's a few different ways that we could do that.
Absolutely. We can actually take that as a takeaway and have you guys do it in the demo system, because the demo system does have asthma and it's cut by that.
No, but in terms of the peer groups, I was looking at different specialties.
Mhm.
The only ones I could find for Medicaid were the PCP specialties.
Oh, the Medicaid
Yeah.
only peer definitions.
I don't know if that's about how we are sending the
Mm-mm.
data.
No,
No,
those are
no.
configurations that WEO has.
Right.
We haven't created specialty peer groups. See, we're in the primary care folder.
Right. We'll slip down to the
Um,
next one.
Why do you have a much bigger list of primary care than
Because you're in the demo system.
Okay.
This is the actual WEO system.
So I just expanded this medical specialty folder, and you have peer groups that are statewide and all payer types. And then you have a subset that excludes Medicaid. We haven't replicated the Medicaid only for the specialty peer groups. That's certainly something that we can do for future data
Mhm.
marts.
Yeah.
So, we can talk more about that.
Yeah. As Sarah said, you guys have about, 40 different peer groups at this
At
particular
least,
point?
yep.
We have clients with up to 500 peer groups. That becomes unmanageable at some point. So you really want to assess whether or not that peer group has enough episodes to support it or not. So for PCPs, the way we've got it set up, you certainly have enough episodes to support every one of those particular peer groups in there. But let's say, for example, you went into one of these and you put in a Medicaid only one. If you didn't have enough Medicaid volume in cardiology to support a peer group, that would be a useless peer group to you. You'd get data out of it, but when you came to try to say, okay, does this provider treat a Medicaid patient differently than that provider, there'd be no statistical significance there, and you couldn't walk into the office and say, hey, this is what we need you to change. So one of the things we look at jointly is, do you have enough episodes to support a specific type of peer group? Let me give you a really simple example. If you look at this list here, pulmonology does not appear to be on the list, right? Pulmonology maybe is a peer group you want. So one of the first things we do is we would go look at the current episodes table that's formed and say, how many episodes really are pulmonology using the ETG construct? Oh my God, there's 7,000 episodes. Well, how many providers can we, oh wow, there's 35 providers. Yeah, that determines a peer group. Versus we go through the episodes and there's 200 pulmonology ETGs and you've got 45 pulmonologists. That doesn't support a peer group because each pulmonologist probably has 4 or 5 of them. So you don't want to do that and have the data sitting there and not have it usable, because it really does clutter this up. And then when you're starting to look, you can imagine if you got 500, but you've got 40 here, and it still kind of takes up the page.
And Raj, to your question at the beginning about percentage of episodes that are being used in performance measurement, that's what we're really talking about here, is the subset of the whole that is complete, not an outlier, year 2 episodes,
Yep.
attributed to a physician who is eligible to be the responsible provider.
Yep.
So that's how you go from here down to here in the narrowing of the funnel, if you will.
Yep, and as Sarah mentioned yesterday, or day before in class, I guess we're using about 14%,
Yeah.
which is not on the low side, but still, 14% of a big number is still a big number. That's why you can support all of this. And when you go down and you start looking at these physicians and you compare physician A to physician B, and we'll do that in a second, you're going to have enough numbers there to be statistically significant for many of these particular categories. So that's the WEO piece of this. Now, if we go through here, now we'll just stay in this, I guess. It doesn't really, okay, we're
Oh,
back
you
to
want
that.
me to-
No,
okay.
that's fine, that's fine. This is good because everybody can see this. Now, the next one is affiliations. Now, affiliations in the demo system are going to start out at the highest possible level, which we call the system level. Now, if you expand out the system level, you're going to get down to the next level, which is the group. Then you expand out the group, we're going to get to the site, and if you expand out the site, we're going to have the individual physician ID. Your WEOs run in the same way, except instead of calling it site, there's actual names in there, and Sarah's going to show you that.
And you have a 4-tier tier hierarchy.
Yep.
We have a 3-tier hierarchy.
Yep. Which is
So-
why it's ABC.
Well, it's 4 tiers, so yeah. So the first tier is simply the first alpha character of the system.
Yep. And let's pick one that has enough to go down.
So we'll go
Yeah,
down to Affinity Health System.
Yep, there we go.
And as you can see at the group level, so Affinity is at the system level. At the group level, you have specific locations. So 1501 Madison Street in Appleton, Richmond Street in Appleton, Kaukauna. And then if you expand,
One more, you get to the
then you
docs.
see the individual physicians that roll into that group.
So, the idea here is, as you're going across the top on the filters, you can select from the general tab, then you can select only cardiologists, and then if you only wanted to see cardiologists that were with affinity, you could check off affinity. That's the only cardiologist that would show up. So those filters are actually narrowing things down for you. You can look at it from a geographic perspective, from a specialty perspective. SQL is an interesting tab, and why don't we click on that tab, because there may be some folks that want to just write their own SQL. In SQL, you can put a where clause right in here. That where clause will affect anything that's in this table right here. Now, we haven't talked about the tables yet. This is the table that lies, where'd it go? Oh, that's the table that lies behind this particular quick list. So if you were to go to the data mart guide and you were to look up that table in the guide, you're going to get all of the fields that are in there. And you're going to be able to then say where field A equals this and field B equals that, or field B equals. So you can, any where clause you can think of in SQL, you can drop in here, and once you submit it, it'll apply it to that particular quick list. So what we're going to do now is we're going to actually run a couple of quick lists out of the demo system, so we're all going to get the same answer here. And what we're going to try to do is we're going to try to select cardiology as the peer group, and we're going to list all the cardiologists, and then we're going to modify that list a little bit so that it makes sense. So if you want me to run that, Sarah?
Sure.
So if you guys want to follow along in the demo system, the first thing we're going to do is we're going to go into medical specialty here. We're going to hit the cardiology button. And you can see what happens. If I only hit cardiology, there's a little red arrow that appears here, check mark. But if I hit it at the level of the folder, it goes green and everything underneath gets checked. So we're not going to do that. We're just going to pick cardiology. I'm not going to choose anything else in here for the moment. And all I'm going to do is go down and I'm going to hit submit. And what this is going to do is it's going to go off and pick all of my cardiologists out. Here they are. And provider name, the time period, the analysis period, population, morbidity, etc. We're going to talk a little bit about this right now because in some cases, the default table that comes up is not the table you want to see. There's stuff in here you could care less about. So for example, we picked cardiology. Cardiologists never have a population. They just don't. There's no panel that go. They see patients individually. So this column is probably useless to you. Morbidity of population, that's a useless column to you, okay? Number of episodes, now that's a valuable column, but sometimes you get providers with 7 episodes, 9 episodes. Those aren't numbers that you can actually be useful to you because you can't walk into a physician's office and say, you did these 7 episodes and you're not efficient. So you want to filter that a little bit more. So what we're going to do now is we're going to kind of modify this list by going up to the columns button and deselecting the columns we don't need and adding in columns that we do need. Yes, ma'am?
So is the population only for like a primary care
Correct.
physician? Okay.
Yeah. Anybody who can have a panel would be the population. If you can't have a panel and no specialist has a panel, we don't do it that way. And that's why when you compare physicians at the PCP level, the PCPs get compared on their overall population. Whether they see the patient or not doesn't matter. They're responsible, right? But on a cardiology or any specialty level, we only look at episodes of care because they saw that one patient for this particular piece of activity. So let's click the columns button. And you should get a list of columns that look like this. What we're going to do is I'm going to go through here and I'm going to get rid of the population buttons right here by just unclicking them. And then what I'm going to do is I'm going to come up here and say, well, I need peer definition. I need the provider ID. I don't necessarily need the provider name. Time period, I don't necessarily need. I'm going to keep analysis period in there. And I'm going to come down till I get to the point where I see statistical significance. And I've got 3 of them: population, quality, and episodes. And I'm going to pick both quality and episodes. You can see there's a number of other things I could pick too. So depending on what you're looking for, you can come to here and you can rearrange it. So now what I'm going to do is I'm simply going to submit that, and it's going to rearrange that list that we had. And now you can see what we've got is we've got exactly what I put in there. And now number of episodes is coming up, the case mix of those episodes, which we'll talk about in a second, number of quality opportunities. This index is all 0. I should have removed it. I missed it. So we're going to go back and do that. There's the index for the episodes, the index for quality, and there's the statistical significance for both of those. One of the things I look at when I develop a template like this and before I save the template is all the data on the template usable? Well, it's great to know that all of these docs are sitting here and we have an index associated with them, but some of these have very low number of episodes. So I'm going to get rid of that. So what I'm going to do next is I'm going to go to columns, and I'm going to get rid of this one that's all 0 because it's population. Then I'm going to go to filter, and I'm going to set that filter at 30. So let's all go off and do that. So first I went to columns, and there's the index for the population that I just got rid of. Submit it again. Now it's all on one page. I'm going to go to the filter button. And number of episodes, I'm going to put 30 in here. You don't have to have a high end. You don't have to say 30 to 1,000, 30 to 3,000. If you simply put 30 in, it's going to take anything above 30. If I was on the opposite side over here and I wanted to limit it, I could put 1,000 and it'd be 1,000 or less. So then I'm going to submit that. And now what I've got is the list that I'm looking for. This is what I consider to be an actionable list. Every doctor on this list has a minimum number of episodes. Every doctor on this list has statistical significance, and it's denoted by either a double star, I don't see one here, but there's a single star as well. A double star, go ahead.
When you limit the number of physicians which are coming up,
Yep.
does it calculate the case mix and other elements again, or is it still based on the original data?
Okay. It's based on the original data because when you create a peer group of physicians, it takes all of the episodes in. Because a peer group, and in this case, I don't know what the number is, but if I added up all of these episodes, there's hundreds, if not thousands of episodes. And what we do is we form an average for each one of those episodes. So we leave them in, but what we do is we try to take out the physicians that have a low number because we don't want to compare that physician against another physician because of this. Yeah. Okay.
I'm looking at other calculations, saying, are you truncating this population
Right.
to calculate the numbers? Or
No.
the whole population?
It's the whole population. Yep. Every single episode that qualified, that's a non-outlier, and that is a complete episode is in these numbers. Yep. I'm sorry.
Provider ID, is that the MPI or is that VO's ID for each provider?
Sarah, I'm going to have to ask for help on that. The WEO provider ID?
It's system assigned.
System
It's,
assigned.
assigned by a P360.
Okay. Now, you can also put the name of the provider in there as well. I didn't. If you wanted to see name instead of ID, you could have chosen that in the column list. That might be more helpful to you. So the next thing I want to do is I want to actually fine-tune this particular list of cardiologists, and I want to see who the best cardiologists are. Now, best can mean a number of things, right? Best in quality, best in utilization. Now remember, Sarah talked a little bit about using standard pricing here. We're using a standard price for everything. So when we compute our overall index here, it's based on standard pricing. So this drives you directly towards resource utilization. So if I were to sort this particular column here, and I were to sort it such that I had the best performing physician at the top, I could then see, are those statistically significant for the best physician? And then at the bottom of the list would be the worst. So how do you do that? Sorting is easy. On any column, all you have to do is hover over the column, like episodes, click it once, and it's going to sort it in one direction. In this way, we have the worst physicians at the top of the list because they have a 1.57. If I sort it a different way, by clicking it again, I'm going to have the best physician at the top of the list. So when we've sorted this, this is typically the way I would sort the list from the best to the worst. What we're looking at here is we're looking at the first cardiologist here has 43 episodes. His case mix is 1.01. Well, what does case mix of 1.01 mean? It means for the episodes that that provider has seen, they are 1% sicker or 1% more difficult. I shouldn't say sicker, that's the wrong word. More difficult than his peers. 1%. If you go down to, let's say, the second one here, 0.69, that doctor had a set of episodes that he treated for patients that were 31% less severe than his peers. So what this is telling us is this first doctor here, he sees just about the average. He has 164 quality opportunities. His index is 0.61. He is a highly efficient doctor in terms of resource utilization. Highly efficient. In fact, 39% better than his peers. Overall quality index is 0.97. He's not quite that good in quality. He's 3% less than his peers. And you can see that statistically, that's not significant. So quality is insignificant. But here, in terms of episodes, he's definitely better than his peers. It is, at the 95% confidence level, significant that he's better than his peers. Now, what do we use these lists for? Many companies will put these lists together, and they will distribute these lists to their PCPs and ask the PCPs to please refer to these doctors because they're highly efficient doctors in the specialty. And as we all know, where's all the cost in healthcare today? It's not in PCPs, it's in specialties and hospitals. And who sends people to the hospital? Is it the PCP? Generally, it's the specialist that sends them there. So if you can pick a highly efficient specialist, you've got half the equation cut up right here. So that's one way to look at this. Now, the next thing that you can do, if you really wanted to, you could investigate that particular first physician by looking at what kind of episodes he treated, anything that's highlighted, bold, and underlined. So you've got the provider ID, the number of episodes, the number of quality opportunities. You can actually drill into and get deeper information on it. So if I wanted to find out the 43 episodes that this guy was doing, we'd click on the 43 there, and you guys can follow right along. Did you click, Sarah? Mm-hmm. All right. I just can't see it spinning up at the top. There we go. And what it does is it drives us into all of the episodes for that particular doctor. And you can see, because that particular doctor happens to be a cardiologist, that the types of episodes they're treating all have to do with things like valve disorders, ischemic heart disease, hypertension, etc. Now, if I wanted to further drill down and say, okay, I want to see the claims associated with that, we've got this little claims icon there. If we clicked on that, we would drill down further into that one episode, and these are all the claims that are appropriate for that one episode. So those claims came together to form that episode came together to be attached to that doctor, and then that doctor became part of a peer group. And again, in each one of those drill downs, as we've gone deeper and deeper into the tool, all we've really done is we've actually gone down this list here. So we started provider network assessment. When I actually clicked on the episode button, it drove me into here. When I actually clicked on the claims, it drove me into the claims. So if I were to click episodes directly, that's the same kind of thing I'd see. If I click claims directly, that's what I'm going to see. In each and every quick list, columns, filter, and save are available. So if you wanted to, at this point here, change the columns like we did before for the physicians, you can click columns here. You can add and subtract columns. There are many, many more pieces of data behind this. So Sarah, if you click on columns on this particular one, and you can see that we've only selected the first few. As you work your way down, there's a lot of other columns that are available to you to actually show on that particular one. There's a ton in this particular one because it's a claim. We're at the claims level here.
247 million claim lines in WIO.
There you go, 247 million. Yes, sir.
I noticed when I was looking at the system that if you put quite a few of them in there,
Mm-hmm.
you can't scroll all the way to the right and see them. You have to like export it. I don't know, is that something that you're looking to fix at the next version? Or?
Actually, if you have a mouse like you have on your desk there, the middle button of the mouse will allow you to actually fix it and scroll. That's kind of like a, I don't know, I think it's a Microsoft trick, right? But otherwise, you have to go way down to the bottom here and use the scroll button way down at the bottom because there's dual scroll buttons here. It's a window within a window, if you will. And there's two
Even
scroll
when
buttons.
I did that in the past, at least in the real system.
Yeah, exactly.
Okay, because it just will show like
Yep.
half of the last.
Yep, I
month.
totally get that. The Internet Explorer version affects it, unfortunately. Compatibility view will help a little bit, but that middle mouse button is a real trick, and that is a great shortcut. So you click it once, it gives you this little icon, and you just move the mouse left and right, and you go zip, zip. Now, you brought up another good point, though. I mentioned the filter button, I mentioned the save button, and I mentioned the columns button. What we haven't talked anything about yet is this little export data button up here. And if you drop that down, you're going to see that on every one of these quick lists, you're going to have the ability to take your data and send it to either a CSV file or to an Excel file. And there's two flavors. You can take the page that's shown and send it, a small subset of data, or everything. Now, what I generally do is I generally use CSV myself because it's the easiest and quickest, and you get what you want. If you do Excel, it brings all the formatting, the headers and the footers and all that stuff in there too. And me being a data geek, I just want the data. I could care less about the headers and the footers. So why don't we, at this point, try save, and we'll show you how you can actually save a report. In every single one of the quick lists, you come up and it says, what do you want to name your report? What's the title in the report? It tells you who the author is, and because you're logged in as me, you'll see me there. And it says, can I save it as a private, a group, or a public report? If I click group report, what it's going to do is it's going to show me which groups I'm a member of and allow me to place the report in any one of these. So I could do it in both, or I could do it in one of them. And then I would just simply submit the changes, which we don't want to do now, and because we'll have a zillion of them. And then it would actually appear, depending on where I put it, private, group, or public. If I put it in my reports, private, that's where it would show up right up in there. Yes, sir.
If you put it in public, but you didn't mean to, it was an accident or whatever,
Mhm.
how do you delete it?
Oh, well, we have the ability here to manage your own reports.
I
Did you
don't
give them
think-
that?
I don't think users have the ability to save to public.
Ah, okay.
I'm not sure, I'd have to check that.
Okay.
If you do, which I don't know if you do, and you want me to delete it, you can send me an email, or you might have the ability to delete it yourself. If you have the ability to save it, you probably have the ability
Yes, you
to
do.
delete it.
Yeah.
Okay.
Yeah, if you have the ability to save it, the manage reports section, and we can just show them where this is the administrative view, unfortunately. I can delete anything in the world because I'm an administrator here. You'd only be able to delete those that you created. But I think, as Sarah has mentioned, I think she's right. I think that at WEO, public reports are disabled, and you can only do my reports or group reports based on the groups that Sarah set up. That way everybody has their own little bucket, and nobody's throwing 1,000 reports out in public. Okay, it's about 9:30 now, and we've been going for about an hour and a half. Why don't we take a 10-minute break at this point? We'll come back, and what I want to do is I'm going to walk us through some of the other quick lists that are in there. They're all identical, and then I'm going to put you to work a little bit. The other thing I want to do when I come back is I'm going to jump into your system, because I wanted to show you some of the differences when we start doing members, episodes, claims, confinements, etc. within your system. So let's take a break and come back in about 10 minutes.